There are so many myths and misconceptions about gene therapy treatment, even for the most well-informed, educated patient. Context, as you know, is extremely important, but also what works for one treatment, one patient, might not necessarily work for another. So in today's segment, I've asked Dr. Mark Redding and Dr. Stephen Pipe to break down the common misperceptions and myths around gene therapy for hemophilia, and in particular, for Hemgenix, the hemophilia B gene therapy treatment. This segment is brought to you by CSL Behring, a global biotherapeutics leader focused on serving the rare disease community by providing innovative therapies. They now have a first-of-its-kind treatment for hemophilia B. To learn more about this treatment option, visit beyondhemb.com and download the B Support app from the App Store or Google Play to stay up to date on relevant information and to manage your treatment journey. Our guest today, y'all. Dr. Mark Redding is a hematologist who sees patients at the Center for Bleeding and Clotting Disorders in Minnesota. And Dr. Stephen Pipe is the medical director of the Pediatric Hemophilia and Coagulation Disorders program at the University of Michigan in Ann Arbor, Michigan. They both speak nationally about gene therapy, about the patient response, and about the data that has been published to date. All I can say is both know their stuff. So let's start off with a bang. Let's really go big or go home with this myth stuff. What is the biggest myth out there about gene therapy? That gene therapy is a cure. Let's hear what Dr. Mark Redding has to say about that.
One of the myths, and maybe it's not a myth, it's more of a misperception, is that it's a cure. How do you define cure? And everybody will have a little bit different definition perhaps, but this doesn't cure hemophilia. If this works really well in you, this could be a really good treatment for you, but it may not work as well in you. Okay, so that we can't call it a cure if there's that chance of it not working very well in a given person.
So one thing that I have heard from patients who are educating themselves about gene therapy, but keeping a healthy distance from an actual decision, is they are waiting for over 5 years of data to be released before they move forward with making that decision. They want to see how long the factor gene expresses before making that call. It sounds smart, super smart, right? Well, actually, there's a bit of a myth to that, because for Hemgenix, the gene therapy treatment for hemophilia B, well over 5 years of data has been published. Here's Dr. Stephen Pipe to tell us all about it.
You may remember that some of the early clinical work in patients with hemophilia B was reported around 2011 through 2014. Well, fast forward, those gentlemen now have been post-Hem B gene therapy with AAV factor IX for more than 12 years now, and the data is showing that they are still expressing factor IX over that whole time period. So all of that went together to give us some confidence that if we had the right vector and transgene combination, we could get durable expression of factor IX in patients with the best risk profiling.
Another misperception about gene therapy is the amount of steroids that are needed to offset immune responses. Here's Dr. Mark Redding to explain.
So steroids is another hot button topic. So to kind of just backing up a bit, like what's the deal with steroids? And by steroids, we don't mean like the bodybuilding steroids, like get your muscles huge, right? We mean corticosteroids, the one that people commonly know as prednisone. And these are medicines that we use to sort of tamp down immune responses. So when we deliver gene therapy, that vector gets into the liver, delivers the gene, that causes some inflammatory immune response in the liver. And if that happens to enough of a degree, we worry that there could be damage to the liver or that maybe the treatment won't work. And so in the clinical trials, we've used steroids to kind of blunt that immune response. Now, the question is this. In some of the clinical trials, most of the patients have had those kinds of immune responses and needed steroids. In other trials, there's been a lot less of that. So in the Hemgenix trial, I think, for example, it was only about 20% of patients that had their liver enzymes elevate, indicating that kind of a response. And most of those patients were treated with steroids. In some other clinical trials, it's been more like 60% of the patients. In others, it's been up to 80% of the patients. Part of the issue when we use steroids is if we use steroids for a short period of time, it's not such a huge deal. But if you need to be on them for a while, there are some side effects. They're not horrible side effects. They're not usually permanent side effects, but it can be pretty bothersome, especially if you end up on steroids for a long time. And in some of the clinical trials, people have needed steroids for many weeks. And that's kind of a bummer.
So, another common misperception is that gene therapy treatment will alter or modify your own genome. Now, while we know that that is true for other gene therapies, that's called gene editing, for hemophilia A or hemophilia B, gene therapy would deliver a working copy of the faulty gene into the liver cells with instructions to produce the missing clotting factor. Dr. Pipe can confirm.
Well, we're not changing your own genome. Your hemophilia doesn't go away genetically. If you have a daughter, your daughters are still going to be carriers.
Okay, here's another one. This is a really big one that we've heard. When it comes to hemophilia B gene therapy, another myth, again, that you might have heard, is that if you have an AAV neutralizing antibody, your body could potentially block the treatment, rendering no factor expression response. We've heard that a lot. Let's hear from Dr. Pipe, who breaks down this myth.
There's a couple of aspects that I think your listeners should understand about AAV gene therapy. And the first one is, AAVs are naturally occurring viruses. We all encounter them in the wild. They don't cause any disease, but we mount antibodies against them potentially. And for almost every platform of therapy that's used AAV vectors, they have screened patients out if they had a certain level of antibody that had the potential to neutralize the virus and basically block it from getting directed to the liver. And so that was a real exclusionary aspect of AAV gene therapy up until this point. Uniquely to this trial with this product, we had some early data that suggested that having AAV neutralizing antibodies might not be an impediment to getting a good outcome with this treatment. So boldly, that small study we did with the first 3 patients with the Padua variant, we enrolled them knowing what their neutralizing antibody titer was, but we didn't exclude them from participating. And they got that really good expression. So that emboldened us for this big phase 3 trial not to screen patients out based on neutralizing antibodies. And what we observed is that except for a single patient who had a really, really high titer, probably at the 90 or 95th percentile of the normal population, he did not get a good response. He didn't respond at all. So there does appear that there's probably a threshold there, but it's not clear where that threshold is. We had all the rest of the patients, about 42% of them had neutralizing antibodies, and up to a titer of about 1 to 700. This is the dilution of their plasma that was used to make this calculation. They all seem to have good response and no safety issues related to neutralizing antibodies. So to date, this is the only AAV gene therapy program that does not exclude patients based on AAV neutralizing antibodies.
So, who is gene therapy for? We say those with severe hemophilia, but is that only based on factor level? Dr. Mark Redding explains.
It's only for people with severe hemophilia, and severity isn't defined just on factor level. Severity includes just what's your bleeding tendency, and so that's sort of a separate conversation. But you have to have severe hemophilia.
So, because I am a nonprofit nerd, my personal favorite myth is that gene therapy is too expensive. There's no way a payer is going to pay for this. However, that is turning out to be a myth. Dr. Mark Redding explains how expensive gene therapy is and if there really is a barrier to access.
So far, that has not been as much of a sort of deal breaker as I think we thought. I mean, it's super expensive, right? There's no question. But look, treating hemophilia is super expensive. The current treatments we have are very, very costly as well. So, initially when you look at that price tag, people are like, oh my gosh, this is so expensive. And, unfortunately we see stuff that makes it to the newspaper, like most expensive treatment ever approved. And that's not helpful to the conversation because when taken out of context, it doesn't really tell the whole story. I mean, treating hemophilia is really, really expensive with the current therapies we have. So that's the first thing to sort of say that. We've been talking about this for a long time. There've been a lot of conversations nationally with the different patient advocacy groups, talking with payers, helping understand, this is going to be really expensive, but what are we getting for that? And and you have to compare the cost of how much it costs to treat hemophilia the way we're currently doing it, and if gene therapy, although it's a one-time really expensive cost, if that means you don't need to use factor anymore, over time that's going to pay for itself. And so getting back to the predictability issue, that's really where the hook is, right? So if you knew this was definitely going to work for you and you wouldn't need factor anymore, then you can do the math and figure out at what point the cost savings would kick in. But because we can't predict how well it's going to work for a given person, and not everybody's going to be able to stay off factor entirely, that makes that long-term kind of cost analysis a lot trickier. So I will say, though, I think that the payers understand this. We've been having lots of conversations as a community, and the payers have been at the table with those conversations. I think everybody understands that, it's expensive, but we have to think about it in the right context and think about, at some point this should be cost effective if we can avoid using factor. So in general, I would say this hasn't been as big of a barrier as we maybe thought it was going to be. There are still some issues to be worked out, and we're just starting to use commercial gene therapy now. More to come on that, but I don't think we should look at this as the insurance companies are going to say no, you can't have this treatment.
Good stuff, right? We learned something, right? Awesome. Do you have another myth or a misconception about gene therapy that's been bugging you? Let us know all about it. We have info in the program notes for how to get a hold of us. And once again, this segment has been brought to you by CSL Behring, which now has a first-of-its-kind hemophilia B treatment. Visit beyondhemb.com or download the B Support app wherever you get your apps for more information.